helps us a mixture of OMOP and I2B2 data repositories across this network. And eventually we'll have also the PicoNet data model become interoperable with this network. So when we moved from the ACT network to the ENACT network, the focus went from cohort discovery. So ACT was initially set up to do cohort discovery, to be able to figure out, for example, given a bunch of inclusion-exclusion criteria, how many patients are available at each of the participating sites, to ENACT, where the focus was more on analytics, to be able to use EHR data for large-scale analytics. So the basic platform that we use basically gets you patient counts. So this is what you get with the Shrine tool when you interact with the network, is for very complex queries, you can get back patient counts. And this does enable some amount of research. So you can do epidemiological research, for example, and I'll show you an example that we have done with just patient counts. And more recently, we are also starting to do queries for clinical evidence. So if there are clinical questions for which there is no gold standard evidence and for which EHR data can be used at scale to answer the question, then you can sometimes just use patient counts to get to that, to provide some kind of a response to that question. But for any deeper analytics, and especially for things like machine learning, you want the data to be available at the patient level, aggregated in a single place, so that you can do the analytics. Even though you can do federated machine learning, it's much, much easier if the data is all available in one place. And so I'll talk about this ephemeral data enclaves, which allows the network to push data for a particular study into a central place where you can then do analytics. So let me just start out with one example where we just used the Shrine tool to get patient counts to do the study. So the study that we were interested in was looking at postpartum hemorrhage. So we did a repeated annual cross-sectional analysis from 2005 to 2022, just to look at things like what's the occurrence of postpartum hemorrhage, what are the comorbidities associated with postpartum hemorrhage, what's its prevalence across various sociodemographic groups, and all of this just using patient counts. And so the volume of data that we looked at was about 1.2 million unique delivery hospitalizations across 22 sites. So the first thing which we noticed, and this was also confirmed by, there is a longstanding AHRQ study which looks at postpartum hemorrhage. And they do this on pretty much every 10-year basis. They actually look at all the inpatient data across the country and put out a report on the incidence and the prevalence as well as comorbidities associated with postpartum hemorrhage. And what you basically notice is that the incidence of postpartum hemorrhage has been going up. And so when we compared this to the HRQ report, which came out in 2020, it actually tracks very closely to what we see from the counts that we obtained from the ENACT network. But what is more concerning is that since 2020, at least based on the network, it seems to be going up even faster in terms of its incidence, and this is statistically significant. We also looked at simple demographics, and so here these bars represent breakdowns in terms of incidence based on race and ethnicity, which are the green bars, in terms of some of the comorbidities like obesity and gestational diabetes, which are the reddish brown bars. And also there are risk factors, and this is looking at the incidence of risk factors. These are the blue bars. And one of the interesting things which came out of this analysis is that among the socioeconomic groups, or rather among the racial ethnic groups, the Asians are at the highest risk for postpartum hemorrhage. And this is something which is really not been there in the literature which has examined US data. So there was something new which came out of this analysis. We also looked at the prevalence of comorbidities in postpartum hemorrhage, as well as the reciprocal prevalence of postpartum hemorrhage in those comorbidities. And some of these track actually very closely to what the AHRQ report produces. And so this was basically, we did the study for a couple of reasons. One, can you use something like a big network which has got access to EHR data, and all you're getting back is counts with your queries, to replicate something which has been done before, which has used patient-level data. So HRQ uses patient-level data to do these kinds of analysis. And yes, to a certain extent, you can actually do this. You can sit down. It's a little bit tedious. You have to run a lot of queries on the network, but you can do this kind of analysis. And so this was a starting point, which then brings up questions like, given that these temporal trends are worrisome, can we do more deeper analysis? So can we do maybe something like a predictive model for postpartum hemorrhage? Now, that is something which can't be done directly on the network just by using patient counts. And so that's where the network started moving into ephemeral enclaves. And the way it is set up in this network is that the idea is, of course, to make patient-level data available, and it's done in an AWS platform. This particular AWS environment that we use in ENACT is managed by UC San Diego on behalf of ENACT. It is study-specific, so it's based on the question that you care about, for which you come up with a definition for the control group and a definition for the experimental group, and only data corresponding to the patients which fall into those two groups get moved into the enclave. So that's sort of number one, that it's study specific. The second is that it's ephemeral, which means that the data only stays in the enclave till the study is completed. And after that, it's archived. And the kind of data that gets moved is limited data, because the ENACT network has always used limited data, so it preserves dates and timestamps. So this enables analysis which are looking at seasonality and things like that. And the other big aspect of this is that a particular participating site has got control over whether they want to participate in a particular study or not. So not every site in the ENACT network has to participate in every one of these enclave studies. So the whole idea was that we wanted to give a lot of control to the participating sites, and especially de-risk the health systems, because they are moving data out of the institution for a study here. And so this enables pretty much very granular control by the participating sites in terms of how long the data sits there and whether they even want to participate in a particular study or not. So as you can imagine, really the heavy lift is the governance piece to get all the sites signed off on this. So previously, the network only shared counts. So the only thing which moved out of the institutions is counts, which comes through the Shrine tool. And so the initial governance, which was set up 10 years ago for this network, which everyone signed off and all the IRBs signed off, was that you could expose counts. But the new governance agreement has been updated so that data, the patient-level data, limited data sets can be moved outside the institution for study purposes. So we started out with basically 4 sites which have signed off on this agreement. So that's University of Pittsburgh, UC San Diego, UT Southwestern, and MGB. And the very first project which we did, and I'll get to that, is on this postpartum hemorrhage. So let me just give you a little bit overview of how this workflow happens. So one of the key aspects of the ENACT network is that you can define the cohort very precisely because that's what it was set up for initially by running queries through Shrine. So to identify a cohort for Enclave, this is what is first done, is whichever site or whichever group initiates a particular study, once it's been green-lighted, then queries are run through Shrine to identify the number of patients available at each of the sites who want to participate. And then each of the participating sites can actually use that query itself to cut the data from their database and move it to the Enclave. So now we have a standardized way of distributing the queries by just taking advantage of the fact that the network always was set up that way. So the problem of sharing a standardized query, which is executable, was very easily solved for us. So then the data moves, and that currently is a manual. It's a manual step. There's a person at each site who will rerun the query locally, export the data out, and move it over to the Enclave. And once it's moved to the Enclave, then the study team can do the analysis, and then the data gets archived after the analysis is done. And the Enclave environment is very similar to other projects like the N3C or the All of Us program, where you have all the standard packages like Python and R and so on and so forth. And typically, you do need a data scientist because most of the analysis is done by writing code, typically in R or Python. So for the postpartum hemorrhage study, so since the governance and the regulatory setup has been sort of signed by these 4 institutions, so these are the data contributing sites at this point for this study. And we moved all the standard data domains that are present in ACT, so that's demographics, diagnosis, procedures, lab results, and medications, which corresponds to the cohort that we cared about, which is all deliveries, basically. And so the data gets moved in I2B2 tables, but at the Enclave, they can be translated into whatever you want. So if you want an OMOP formatted set of tables, we can do that. And when we started out, we actually had 3 sites, and that was about 500,000 deliveries, but now we have actually the 4th site also onboarded, so it's actually about 750,000 deliveries for this particular data set. And as we basically get the governance out to the rest of the network, which gets rolled out later in the summer, we will probably end up actually importing more data for this particular study. But as you can see, just with 4 contributing sites, we are able to get to a pretty big sample size. And we've just started to do some initial analysis on this particular data set. And so this is only looking at 3 sites. And what this is basically looking at is comparing the prevalence of the 15 risk factors and comorbidities that we had sort of identified from the previous study, which looked at counts. And what's pretty interesting is that the prevalence of these risk factors and comorbidities, some of them especially can be quite different across the sites, and that reflects the population that these sites have. And some of these sites are big systems, like, for example, actually 3 out of the 4 are pretty big health systems, UT Southwestern, University of Pittsburgh, and MGB. UC San Diego is a smaller system in terms of the volume of patients, and it's a very different population is what we are seeing. So we also have done some just initial prediction modeling with this to be able to predict who is at risk for postpartum hemorrhage. And if you just do something very simple and very naive, which is develop a model with one site and evaluate it on a different site, the performance is only at around 60% in terms of the area under the curve. And then once you start combining data from multiple sites, then you can bring it up to a much higher level, like 76%. But this also points to a problem that more and more is becoming obvious in using machine learning models for clinical purposes like in decision support, is that when you develop models from data from either one site or multiple sites and you take it to a new site, there's a very good chance it won't perform well. And that's what pretty much we are starting to see, is that one, even the prevalence of PPH is very different. At two sites, it's about 7.5% to 8%. And in a third site, it's only 3%. And even that changes how a model performs. And the risk factors also are very, very different. We are noticing across the sites. The practice of medicine is probably different across the sites too. So what gets coded in the EHR probably changes from site to site. So it's not just the actual health condition, but it's also what gets captured in the process of care, which makes a difference. And the models are consuming both. And so the sort of the most interesting thing that I think we're going to learn from this is the heterogeneity of trying to build these predictive models, which we are hoping can generalize across sites. And it's not quite clear whether it will actually be possible to build a single model for any clinical task, including something like postpartum hemorrhage prediction, which will generalize without fine-tuning at each of the sites that it's going to be deployed on. But that's the kind of things that we can do with Enclaves. And since it's study-specific and the definition for the cohort is embedded in the network itself, it can be reused as each new site comes on. So yeah, there are some more Enclave projects that we are starting to bring up. So the second one is predicting progression to end-stage renal disease in chronic disease patients. And there are a few more in the works. So in terms of the number of projects, we are going to be increasing the number of projects, as well as in terms of the number of sites which will be contributing data. That will also expand as other sites sort of sign off on the governance. Yeah. And if you go to the ENACT network website, there is more details on how to participate in the Enclaves. But if you're also part of the network, you will hear from us in terms of how to get onto Enclaves and what the institution has to do in terms of the governance aspects. Okay, thanks.